Welcome back, clinical problem solvers, to another Friday edition of VMR with yours truly, R and R, Reza and Reza. So,
just because I didn't interrupt
you're there. How's it going,
here?
Robbie?
What's that?
I said, oh my gosh, you're there. How's it going?
You know, I usually interrupt Reza in the middle of his welcome back, but today I decided to be a little bit more generous. And here I am getting punished for my generosity in the form of complete anonymity and non-existence. You know how you can tell that I'm not Reza? Look, see that?
You're not as handsome.
That's right, exactly. That's exactly what I'm implying. Yep. All right, I'm gonna shut up now.
Oh man. No, never shut up. But I'm very excited for today because we have the terrific Gerline presenting, and and it was just her birthday, so this is sort of her belated birthday gift to us, I guess. Thanks for being giving, Gerline, as opposed to being the recipient. Do you want to say a few words to the audience?
Thanks so much, Reza. Yeah, I'm so excited to be here, present a case to RLR. Yeah, I'm excited to learn.
And Gerline, you're on track to become a cardiologist, right? And are you in your second year, or are you still in your first year at Brigham?
I'm in my first year. I'm an intern.
Okay, very good.
Mm-hmm.
Excellent. And who's doing the teaching today? Is it Kirtan or Rafa? Or neither?
Rafa is pointing upstairs to Kirtan, I think.
I think Maria is doing that. Yeah, I am scribing.
If you guys want to break, I can help out. So you tell me.
I thought I was scribing, but I can do anything. Just let me.
Maria, I guess you're doing the teaching today.
Hey, awesome.
And thank you, Travis, for always being on deck for us. We appreciate you. Why don't we get this case started? If you want to take over the board, and Robbie, you can tackle the first aliquot, and then we'll go from there.
Okay, so this is a 40-year-old male presenting with, he has no past medical history, presented to a neighboring hospital with 1 month history of right facial droop. He said he developed some right eye twitching. It was difficult for him to close his right eye fully, and when he was drinking water, he had water coming out of his mouth, and he'd noticed a right facial droop. So he went to the emergency department at another hospital where he was diagnosed with Bell's palsy and then treated with a short course of prednisone, but his symptoms did not improve. That's the first aliquot.
Hey, Gerline, you're already off to a racing start. I feel like we're going at 1,000,000 miles an hour, and I'm inclined to speak at 1,000,000 miles an hour, but Reza's been telling me to slow down. And so I hear his voice in my head even right now as he sits there right next to me. And one thing it would be helpful to slow my mini panic is to know if the patient is 40 or 4, because I'll be way more nervous if we have a 4-year-old with Bell's palsy or a concern for Bell's palsy. Is it 40?
40,
oh,
yeah.
5. Thank you. Because I was worried you were doing a secret med peds or peds residency along with your intern year. So I will tell you for sure this patient does not have Bell's palsy. And here's why you have to, here's what you have to remember forever. So the world that Bell's palsy even enters the calculus is the world of a mononeuropathy. Now, a mononeuropathy is relatively rare, but it invokes the idea that only one nerve is down. That's less common in the world of neurology than polyneuropathy, where multiple nerves are down, usually in a symmetric distal fashion, such as that occurs in patients with diabetes or alcohol use, and so on and so forth. But believe it or not, mononeuropathy is not super rare. It's just less common than polyneuropathy. And the reason that Bell's is not super common is because most mononeuropathy, again, a tier that exists under polyneuropathy in terms of frequency, most mononeuropathy is compressive in nature. Carpal tunnel, tarsal tunnel, and many other examples of when nerves are compressed, either when they come out of the spinal cord or through fancy tunnels in our body. Bell's palsy is one of those rare scenarios where you have a non-compressive mononeuropathy, and that non-compressive mononeuropathy is that of the facial nerve. But you have to be careful when you call what you think is a mononeuropathy of the facial nerve, Bell's palsy. Those are very different things. Mononeuropathy of the facial nerve has a differential diagnosis, and the reason it gets conflated with Bell's palsy is because Bell's palsy is the most common cause of a mononeuropathy in cranial nerve 7. Just because it's the most common cause doesn't mean that when you add important modifiers, it becomes unlikely. And here, Gerline, you've given us two important modifiers that make it very unlikely. So what is required for you to diagnose Bell's palsy? You need 3 fundamental things. It needs to be an isolated cranial nerve 7 mononeuropathy. If there are cranial nerve 5 feature or other features, it's not Bell's. So it has to be isolated. It has to have a specific onset and a specific offset. The onset is usually on the order of a few days, and the offset is usually on the order of 1 or 2 weeks. So it has to be isolated. It has to start slowly over the course of days and then improve slowly over the course of a few days or weeks. And then, importantly, there has to be no other systemic or neurological findings. What does that mean? You can't have fever in Bell's palsy. You can't have weight loss in Bell's palsy. And you cannot, importantly, have twitching in Bell's palsy. Twitching is a red flag for a secondary cause of cranial nerve 7. So I'll pass the mic to Reza to reflect on what he might be thinking in this space. That I will tell you, when I hear facial droop, the first thing is to, I should have mentioned this earlier, is to establish if it's upper motor neuron or lower motor neuron, which I'll pass the mic to Reza to reflect on since I rambled. But if you're invoking Bell's palsy, remember that the patient has to have 3 things. It has to be isolated cranial nerve 7. It has to be slow on and slow off over the course of a few days or a week. And it has to be isolated. No systemic features, no other neurological signs. And here, 2 of those rules are broken. It's protracted. It's already been a month. And there's ipsilateral twitching, which is a red flag for a non-Bell's cause. All right, Prof. Rez, take it away.
Yeah, I think that's brilliant. When to question a common cause of a 7th nerve palsy. And I think I'll just take a step back for the audience to just even discuss, where you were going to go, Robbie, the difference between a peripheral 7th nerve palsy and a cortical lesion. And you have to think about the cortical bulbar tract like you think about the cortical spinal tract. So my contralateral cortex, motor cortex, is going to send a signal that will ultimately cause my face to be able to smile, frown, raise my eyebrows, puff out my cheeks, etc. What's responsible for facial muscle movement is the 7th cranial nerve. It controls all of your facial muscles. It has other roles too, and that's going to be important because your first step in someone with a facial droop is to distinguish a upper motor neuron lesion from a lower motor neuron lesion, meaning at the peripheral 7th nerve. So how can we make this distinction? Think about the face divided into 2 parts. You have the upper facial muscles and you have the lower facial muscles. The key is that the lower facial muscle only has contralateral cortical input, while the upper facial muscles have bilateral cortical input. That's critical. So if someone has a stroke, and by the way, when I say upper, it could be cortex, subcortical, it could be at the level of the pons. So when someone has a stroke, you're only losing the lower facial muscle, the contralateral lower facial muscle. Why? Because the upper facial muscle has input from the healthy side. It's bilateral input. You might ask the question, why have we evolved to be this way? Why does the upper facial muscles have bilateral input while the lower facial muscle has just contralateral input? I read this in Aaron's neurology textbook, and he speculates that the ability to close the eyes are more important than the ability to be able to smile. So if you're having a stroke, being able to still close the eyes protects you from ulcers and keratitis. So one way you can distinguish brain versus lower, and you don't need to get a scan in everyone that comes in with the peripheral seventh is to just look at their upper and lower. So look at the lower, but also look at the upper. So if the upper is involved, you won't be able to wrinkle your forehead. And it's interesting, the facial muscle and the peripheral seventh is also involved in closing the eyes. So if that's defected, you won't be able to, so the eyes are open and you lose the nasolabial fold and you have a facial droop and you may lose taste in the anterior third of the tongue. And finally, you might have hyperacusis on the side of the peripheral. This is all like, so the peripheral seventh is facial motor, but also involved in closing the eyes and the anterior tongue and then the sound. The sound is, it's really, you can do it with a tuning fork. I'll leave it at that. So I'm going to be very interested in the physical exam, because if we're less concerned for a peripheral seventh and we have a facial droop, then we have to explore the contralateral cortex as a primary site of lesion.
Great. I learned so much from that discussion. So I have some more information about the HPI. So 3 weeks ago, he began seeing objects side by side, and it was worse when looking to the left. He wore a patch over his right eye, which helped his symptoms. He also had some blurry vision in his eyes. No changes in voice or swallowing difficulties. Has also had some intermittent diarrhea, fatigue, night sweats, chills, and some weight loss. And then around 1 week ago, he noticed that he had left greater than right leg weakness and had some difficulty standing from the sitting position and felt like he was like tripping while walking. He had several falls, didn't notice any numbness or loss of sensation, no urinary or bowel symptoms, no headaches or neck pain or back pain. And then he also got some nausea and vomiting with some shortness of breath 1 week ago. And that's why he represented to another outside hospital emergency department. And at that time, they did some basic labs and he had a sodium of 130 at that time. COVID was tested, which was negative. And the exam from that outside hospital noted a right facial droop and left greater than right lower extremity weakness with areflexia. Kind of unclear details. I don't have the full exam from the hospital, but that's what I found in the notes. And then he was discharged from that hospitalization, or sorry, just the ED with PCP follow-up, but then his symptoms persisted and he also had a fever, so he represented.
Oh my gosh, so much information. I'll just speak maybe for a couple minutes and then pass the mic to Robbie to pick up where I leave it and to clarify stuff for all of you. I think we need to take a step back here, guys. In aliquot 1, Robbie, wasn't convinced that this was a peripheral seventh nerve palsy based on the information presented. We have to take a step back and go to the equation that the neuro DDX is equal to localization times time course. This is we're dealing with a neurologic syndrome here. So maybe I'll focus on the localization or try to focus on the localization and then leave the rest for Robbie to tackle. With the localization, just approach it very basic. Is it upper motor neuron? Meaning, is it the brain stem, the cerebellum, the spinal cord? Or is it lower motor neuron? Meaning, is it the nerve root, the dorsal root ganglia, the peripheral nerve, the junction, or the muscle? How do we make this distinction? Well, decreased reflexes prioritize a lower motor neuron process. There's one exception to this, and that's when you have cauda equina. There you will be hyperreflexic, and even in the acute setting of a myelopathy, you might be hyperreflexic. So right now we have one favoring lower motor neuron. So again, peripheral seventh, the junction, the muscle. The other features we'll look for is going to be Babinski's, clonus, maybe Hoffman sign, and we'll get that when we get to the physical exam, meaning are we dealing with an isolated lower motor neuron or upper motor neuron and lower motor neuron? I'll tell you right now, it's interesting. Okay, so let's say we go down the path of localization. So this patient has their leg weakness. It was on the left side, I believe. Is that right? Left side. So that would mean if it's on the left side, it could be in the right hemispheric cortex, or the ipsilateral spinal cord for the upper motor neuron process, or the peripheral nerve, the junction, the muscle. Now you have a lesion, which is the right facial droop. This has to be above the spinal cord, above the spinal cord. So we're dealing with lesions above the spinal cord for sure. We're definitely dealing with a component of a lower motor neuron process. Above the spinal cord, you have the contralateral hemisphere. And then you can go down to the ipsilateral brainstem, the peripheral nerve, the junction, the muscle. So right away, when I'm doing this localization exercise, one, it's like hard for me to pinpoint like upper motor neuron, lower neuron. It might be both. And then two, I'm worried about a disease for sure above the spinal cord, for sure, and maybe multifocal involving the below the spinal cord. And where does this put me at? Either a polyradiculopathy, multiple cortical lesions, a neuromuscular junction disorder, or a demyelinating process. Basically, I made no progress. It could be anywhere in the nervous system. Hopefully that was helpful.
You know, I think that's awesome. That's super, super helpful. You're like using your hyperreflexia as your anchor and moving from there. I think what's really interesting is to reflect on how often how rare ocular muscle disease happens in systemic disease. And just like hyporeflexia, the presumed diplopia, which, you know, he says that he has double when he sees to the left. The presumed diplopia is a powerful clue because diplopia is often spared in many systemic diseases. For example, you won't see diplopia in amyotrophic lateral sclerosis. Diplopia is a rare feature of most of the things that we invoke here. So a good helpful filter is to say, well, how does the diplopia influence our analysis? And you know, it gives credence to the possibility of a lesion in the brainstem or a lesion in the subarachnoid space that abates the CSF, and that might be a nice place to think of a very patchy distribution of neurological disease. It also then invokes the possibility of a demyelinating neuropathy like Miller-Fisher, which we'll talk about in a moment, but then reinforces the possibility of a neuromuscular junction disorder like myasthenia gravis. But I think, you know, the interesting things about this case are there seems to be a systemic signature of this disease with respiratory components and GI components, and that may be true and unrelated, or it may be a consequence of autonomic neuropathy with dysmotility and aspiration or diaphragmatic weakness. So those may be simply a sequela of the neurological dysfunction. But I think one key question to always ask is when you hear the words areflexia is, could this be acute inflammatory demyelinating polyneuropathy, AIDP, which is the umbrella term for things like Miller-Fisher and Guillain-Barré syndrome. And the only inconsistency here is the time course. By definition, AIDP requires that your patient's nadir, their peak neurological symptoms, occur before the 1 month mark. Otherwise, you might have to invoke AIDP's cousin, which is CIDP, chronic inflammatory demyelinating polyneuropathy, which is a disease that is demyelinating and actually pretty hard to diagnose because just like AIDP, there are no specific biomarkers. The involvement of the ocular muscles in CIDP is super rare, but possible. So I don't know where this case is going to go, but I think the action step for the peripheral nervous system, unlike the central nervous system, the peripheral nervous system is to do an EMG and nerve conduction studies, unlike the central nervous system, which is often imaged. But RESA share two possibilities that might land us at the interface between the CNS and the PNS, that being a lesion of the lower motor neuron inside the central nervous system, like an anterior horn disease, or a polyradiculopathy, which is very possible. So I still think you probably need to take pictures that study the interface of the central nervous system and the peripheral nervous system. And if that's unrevealing, then go on to sample the CSF to see if there's disease there, and then otherwise an EMG nerve conduction study. So we'll see where that takes us. There's a lot left to study, but I think our two most powerful filters are, why does this patient have no reflexes, and why are the ocular muscles involved? All right, Gurleen, back to you.
Yeah. So in terms of no past medical history, not on any medications, for no relevant family history, for social history, smokes 1 to 2 cigarettes in like occasionally, quit drinking alcohol 2 months ago, some marijuana use, works as a construction worker. And then in terms of physical exam, his temp was 36.7, heart rate 112, blood pressure 126/60, respiratory rate 18, setting 96% on room air. In terms of his physical exam, he was alert and attentive. For eye exam, his visual fields were full to confrontation, pupils equal round reactive to light and accommodation. He did have a right abducens palsy without any paresis of his gaze, an intact up and down gaze. And he was noted to have some nystagmus in the right eye with left-sided gaze, and diplopia on exam with left-sided gaze as well. Otherwise, he had, his lungs were clear, cardiovascular exam. He had a flow murmur 2 out of 6 over the left upper sternal border that was documented on admission. Abdomen was mildly distended but non-tender. And then for his more detailed neuro exam, so he had right upper and lower facial weakness. Sensation was equal in his face. Hearing was intact, no tongue deviation. Shoulder shrug was equal and strong bilaterally. He had full strength in his arms and his right leg. He had left leg weakness in the L5 to S1 distribution. So that was with ankle dorsiflexion, inversion, eversion, and knee flexion. His reflexes were 1+ in the biceps and brachioradialis and absent in the patellar and ankles. And then he had equal sensation to light touch and pain in the lower extremities and upper extremities. His finger to nose was intact. No lower extremity edema, no rashes. That's the end of this aliquot.
What an incredible exam, Gurleen. I think you've really helped us understand the you've really helped us understand the signature of this disease on exam. It really maps on very well to what you were describing on the history. And maybe what I can do is I can just focus on the face findings and ask Reza to incorporate everything else. And it's really helpful that you found a pattern of both upper involvement and lower involvement of the facial nerve that confirms that the lesion is at the facial nerve nucleus or distal, since it involves both upper and lower face, as Reza alluded to. So we can now move a little bit away from a cortical lesion, but that doesn't move us away from the brainstem, because remember, the nucleus itself can be involved, or the peripheral facial nerve as it enters through the CSF in the subarachnoid space. And you found diplopia, and I think the right-sided abducens palsy is yet another nerve that's involved, and you might guess the mechanism of the abducens palsy based on the mechanism of the facial nerve palsy, which, while you don't have any evidence that that is not central in origin, there's no reason to think that the abducens would be central and the facial nerve would be peripheral. So you're essentially accumulating multiple cranial nerves, and the more you accumulate multiple cranial nerves, the more widespread and systemic your disease is. So I think you can comfortably say this is definitely not Bell's palsy, and the lesion is in the brainstem or distal to it. The argument of a true brainstem lesion is that there doesn't seem to be a proportional systemic signature, really. Then the weakness in the legs is there and it's notable, but the reflexes are down as opposed to up. And it would really take a very strategic brainstem lesion to affect 6 and 7 on the same side and not cause anything else. So I think it's still possible, but it makes it a little bit less likely in my mind. All right, I'll pass the mic to you, Rez.
Robbie, I'm right there with you, and I'm at the edge of my seat. What a phenomenal case that's being presented. I think that what this exam does with the hyporeflexia, like this degree of hyporeflexia, tells us that there's some kind of peripheral neuropathy. There's some kind of peripheral neuropathy. And so how do we marry that with what's happening in the face? It would be easiest to explain either through a demyelinating process, in my opinion, or a neuromuscular junction process. Now, I'm going to be very slow here. Usually neuromuscular junction processes don't cause this degree of hyperreflexia. So this degree of hyperreflexia prioritizes sort of a demyelinating process, like some of the examples that Robbie mentioned, specifically acute inflammatory demyelinating polyradiculopathy. But there are exceptions. And I believe if you have Lambert-Eaton myasthenia, you can get some hyporeflexia. I don't know about areflexia. And the reason I bring that up is the patient's hyponatremia, probably related to vomiting and diarrhea. That's good enough to explain it. But I'm trying to think, are we dealing with some kind of peroneoplastic syndrome? And is this a clue to SIADH? So I'm going to be very interested to see what happens to the sodium. At this stage in the case, I have a good alternative explanation. But if I were to prioritize amongst the processes we talked about, polyradiculopathy, interesting, but I think the areflexia just really, for me, prioritizes a demyelinating process. And if you ask which one, I think that Miller-Fisher variant or some kind of variant of Guillain-Barré would probably be most likely. Kirtan presented us a phenomenal case. I think of his brother, if I'm not mistaken, which you guys can refer back to for excellent teaching by Kirtan. Anyways, I'm going to pass the mic back to Gurleen and just say that where we are now is MRI brain, entire spinal cord, likely lumbar puncture to evaluate for like albuminose cytologic dissociation, which is not specific to Guillain-Barré, can happen in other instances. And to go from there, and we need to ask the question, does this patient need some kind of immediate therapy in the form of Plex, IVIG, or rituximab?
Yeah, so I have some labs and imaging for you in this aliquot. So for labs, CBC, white blood cell count was 1.7, which was 16% neutrophils, 65% lymphs, 6% monos, 12% other, with an absolute neutrophil count of 270. BMP, sodium 143, potassium was normal, chloride was normal, bicarb 23, creatinine 1.13, phos was normal, calcium was normal, albumin was 3.1, LDH was 1,649, uric acid 13.8, ALT, AST, alk phos, total bili were normal. In terms of, sorry, one second. Yeah, he had a UA with some moderate protein, trace ketones. Some more information from the other hospital. He also got a ganglioside G1QB antibody, which was less than titer. And then some more imaging from, he had a CT abdomen and pelvis done at the other hospital, and then an MRI brain and spine at our hospital. So the CT abdomen pelvis showed small bowel thickening, dilated duodenum, mesenteric lymphadenopathy with splenomegaly and gallbladder wall thickening, a pulmonary nodule measuring 3 millimeters. He had an ultrasound done which showed echogenic heterogeneous liver with some possible liver parenchymal disease and some gallbladder sludge and small volume ascites. And then the MRI brain spine, as you guys had wanted. So the MRI brain showed a abnormal enhancement within the right, along the course of the right facial nerve, along the right trigeminal nerve, including right Meckel's cave, which appeared expanded. And then there's also abnormal enhancement within the right foramen ovale, the right foramen rotundum, all along like the right trigeminal nerve branches. And then the MRI spine showed some diffuse decreased T1 hyperintensity, which was non-specific, and multiple suboccipital and intrathoracic prevertebral lymph nodes. I'm sorry if I talked too fast. It was a lot of information.
Wow. A lot of information here. And Roy, maybe I'll just do this reflexively. Like if we step back to like even aliquot 1, we could have said, is the process a mononeuritis multiplex? right? Two non-contiguous nerves. And we could have created a DDX, meaning that we were in this world of neuropathy. We know it's just not a single mononeuropathy. We know it's not the classic polyneuropathy. So you're left with mononeuropathy multiplex and that DDX for it. Why we didn't lead with that is because it's just an unusual pattern, but not that I have a lot of experience with mononeuritis multiplex. The reason I bring this up is because if you look at this case from that lens, right away, you could have listed the DDX as some form of inflammatory process like a vasculitis, MATSAM, or multifocal mononeuropathy, some form of infection like HIV, Hep C, leprosy, and Lyme, or some kind of infiltrative disease like neurolymphomatosis or amyloid. And the reason I was prompted to think of this is that really high LDH. Like, we're not dealing with hemolysis, we're not dealing with end organ turnover. It really prompts consideration of lymphoma. And if you say lymphoma and multiple nerves down, then you think about the lymphoma infiltrating the nerves. So at this juncture, you have lymphadenopathy, you have what seems to be like a mononeuritis multiplex, and you have very high LDH levels. So the greatest concern would be lymphoma, and the bowel may also be involved. It's the most common extranodal site. You have splenomegaly. So at this point, and even the leukopenia, at this point, for me, what's prioritized is lymphoma. Though before rushing to that diagnosis, you have to rule out infections, and you have to rule out autoimmune processes. What autoimmune processes cause lymphadenopathy? Stuff like lupus, sarcoid, Sjogren's. So I would send an ANA in this case. I would also send the viral hepatitis panel, Hep C, HIV. And I mean, we are in Lyme territory, but for Lyme to do all this, I just don't think that would be consistent with Burgdorferi, the leukopenia and stuff like that. It's definitely consistent. So that's sort of where I am right now. I know Robbie is busy, but basically I'm stepping back. I want to definitely explain the LDH elevation. I want to explain the lymphadenopathy. I want to frame this more of a mononeuritis multiplex. I want to evaluate for inflammatory vasculitides, the common infections that I mentioned, and lymphoma. And I think ultimately in this case, after we send the serologic workup, if the ANA is negative, if the viruses are negative, the infectious workup is negative, you're going to need a tissue sample. And I think the best way to go about this is to do an excisional lymph node, because I am worried about lymphoma. I want to preserve the architecture. So see which of those nodes you can go after.
Yeah, so some more information. So in terms of infectious workup, all of it was negative. So HIV, cryptococcal antigen, T-spot, Lyme screen, galactomannan, beta-glucan, HSV, EBV, parvovirus, hepatitis. His ANA was negative as well. And then he had an LP, which showed 52 of protein. Glucose was 33, 53 nucleated cells, in which 93% were other, 3% lymphs, 2% monos, and the initial flow cytometry showed 16% blasts. And then this is the last aliquot before the final diagnosis.
Hey, Robbie, just to catch you up, very high LDH, splenomegaly, lymphadenopathy, concern for lymphoma, we've ruled out infectious processes, and then we got this LP result.
Awesome. Thank you for catching me up. Yeah, I heard, it's funny. I was listening in peripherally, and then I heard the word blasts. Is that right, Gerline? Yeah, it's amazing what that word does. I think, yeah, I've learned to be careful because the automated machine can call blasts that are not necessarily blasts, that may be activated lymphocytes or monocytes. So the first key step when you hear the word blasts, because of the potential implications for the patient, is to make sure that you're not dealing with a mimic of blasts like activated lymphocytes or monocytes. The word blast should never be anywhere, period. And the fact that there's such high percent blasts in the CSF is very concerning. And diagnostic in this instance of some sort of acute leukemia. And the question is, what is the nature of that leukemia? Because that has profound implications. And my short, very simple schema is to make sure as an internist that we're not missing acute promyelocytic leukemia, or APML, which, as this case tends to present with cytopenias as opposed to leukocytosis, and usually has, in the vast majority of patients, marked coagulopathy and a risk for DIC and spontaneous hemorrhages, usually in the brain. And the time course here, along with the lack of coagulopathy, is reassuring against that. And we'll have to look to make sure you're not dealing with our rods. And ultimately, of course, you'll do a bone marrow and look for the T15, 17 translocations. That's one key question. The other question is it myeloid or lymphoid leukemia? And in adults, AML is much more common than ALL. Though here in California, we're learning that a subset of the population at older ages has a risk for ALL, and ALL tends to be much more common in kids. So here, I think, as Reza was alluding to, the case for lymphoma and a liquid tumor is very strong. And now the nature of the liquid tumor is more likely to be a progenitor tumor like AML or ALL. My understanding, and this is kind of like this is knowledge that you've picked up, but you should probably check, and I'll just share it with you and you should check it, is that ALL tends to be more invasive in the CNS, and it also goes to the testes more often. So I'd be checking and learning about that and relearning about that. But this is a very unfortunate case, and I think highlights what Reza was doing with the mononeuritis multiplex. And this is essentially infiltration of many nerves in many different places, which we saw on the MRI. And yeah, those are my reflections. And I'll pass the mic to Reza to see what he has, and we'll learn what this patient has at the end.
I love it, Robbie. I think that is brilliant, and looking forward to learning from Gurleen as to what unfolded. And Gurleen, thank you so much for this excellent presentation and bringing this to VMR.
Yeah, so the final diagnosis, so flow cytometry showed, based on the markers on the cell surface, that this was most consistent with acute myeloid leukemia with monoblastic differentiation. And that was also the diagnosis from the bone marrow biopsy. So ultimately it was AML with monocytic differentiation with CNS and extramedullary involvement. So in terms of his course, he got intrathecal methotrexate and then was induced with FLAG-IDA chemotherapy. So FLAG-IDA has fludarabine, high-dose cytarabine, idarubicin, and G-CSF, and this is better CNS penetration than the typical regimen that's used for AML, which is the 7+3 chemotherapy. So in terms of CNS involvement, it is more common in ALL as compared to AML, but for AML, it's more common when you have monocytic component and monocytic differentiation, which is what this patient had in terms of the molecular and cytogenetic things. And then it's also more common with certain like inversion of chromosome 16, as well as like the FLT3 mutation. It's more common in those, and you can commonly see hyperleukocytosis, which in this case, it was more cytopenias. And then it's also more common with like elevated LDH. Yeah, so I learned a lot from this discussion. It was a very interesting case that started off with like a neuro kind of DDX, and then it was crazy in terms of how it evolved. I think in real time, it's different because I was on oncology and you already like know that this is some sort of cancer, but I really liked how you guys talked about all the different other things to consider when you're thinking through the case in retrospect.
I absolutely love this case. I think it deserves a cognitive autopsy. I know Robbie will do one. I think for me, the cognitive autopsy is one, when to question the diagnosis of idiopathic peripheral seventh nerve palsy being Bell's palsy. But then two is like when you're localizing the lesion and you get such a patchy distribution, in addition to thinking about neuromuscular demyelinating, to be open to polyradiculopathy, plexopathy, and mononeuritis multiplex. Because I think, and then if you add that layer of inflammation, then I think that really does limit the DDX. And we would have thought about vasculitis, infections, and infiltrative processes. And then I'm adding leukemia, the stuff that infiltrates the nerves. I had lymphoma, but I didn't have leukemia as part of my illness script.
Yeah, I absolutely love that reflection. And I think, you know, it's amazing. You might ask yourself, what's the point of cognitive autopsy when you reach the correct conclusion? I mean, it's a cognitive autopsy because you can reach the conclusion with more clarity, with more understanding, and more efficiency. And for me, you know, I actually will confess that ophthalmoplegia or diplopia was on my mind because I recently just was practicing a case and it came across it. And that's why I probably was comfortable talking about that and prioritizing that. And so here's my reflection. I literally just opened this up again to review it, and I'll do it the same with you all. So ophthalmoplegia implies the probability of diplopia, and we talked about brainstem disease and subarachnoid space disease. And then I was looking, as we were talking in this case, I was like, you know, what is this systemic disease that causes diplopia? And sure, there are many things in the subarachnoid space, like this patient has carcinomatous meningitis. He has blasts in his subarachnoid space, so we definitely get a hit here. But then if you look at all these other ones, none of these are actually cause any systemic complications. Botulism, they're all pure neurological diseases. Pure neurological, all this compressive stuff, pure neurological. So I'm learning now, and I'm going to work on a schema, as I made a little to-do list for this, of who gets ophthalmoplegia with systemic symptoms. And at first glance, this needs more reflection, is I bet it prioritizes diseases that go into the subarachnoid space. And then these diseases, GCA, I'll think about more, which, you know, this patient is too young for it. Age 40, automatically gone. So if you look just at this page alone and you say, which of these patients gets systemic symptoms, I think the only overlap that I can see is this. AIDP, no, you shouldn't have a spleen with AIDP, like none of this stuff. So my cognitive autopsy is that I learned from this case that ophthalmoplegia is usually an isolated neurological syndrome, and the presence of systemic symptoms really seems to localize the DDX to malignancy, but that is very loose and probably is erroneous, but a place to start for me, and I'll spend some time reflecting on whether that's accurate or not going forward. But you know, this is the value of VMR and the value of learning with people like Reza, who take the conversation to such a high level, and people like Gerline, who take such a complicated case and lay it out in a very, in a way that makes it so awesome to break it down and understand it and put narrative. And there's no better way, I think, to end this case than to relearn the journey that we just went through, courtesy of the one and only Maria.
Oh my God, it was so much fun. I really loved how it started. And, you know, if you think of Curtin and you think of vasculitis, I wish people think of me and think of like GBS and GBS variants. So I was really excited at the beginning. And one of the things, like I was talking with Curtin through, and like he was saying like all of these like rare diagnoses. And I just thought, I don't want to bias myself to thinking this is neuro. And I think that's something that I jumped like really fast, thinking something neuro is neuro. And this was a great reflection of not everything that looks neuro is neuro. And I agree, like with neuropathies, they're very interesting. Most minor neuropathies, as Robbie said, are compressive. Bell's palsy is, you know, that not every cranial nerve 7 mononeuropathy is a Bell's palsy, and for that you need it to be isolated, very specific onset and offset, and no other systemic or neuro findings, which, you know, was a hint at the beginning that we might not have the correct diagnosis right at the start. With facial droop localization and like really anything in neuro, the first division you have to do is like central versus peripheral. For that, you know, you can use the upper motor neuron signs and lower motor neuron signs. And, you know, for facial droop, you think upper versus upper. So upper or central lesions are not going to have any affection on the, like the upper third of the face. Unless you have like bilateral cortical lesions or things like that, which are rarer. And then I love the point of mononeuritis multiplex, because with neuro, we tend to really want to have like a localization. And it was funny because Robbie at one point said that, you know, with more signs and symptoms, we have like a more like a spreader disease. And I was like, no, that is like against neuro like principles. You know, with more signs and symptoms, you should really definitely have like a more concrete and specific localization, except for the point where you get multiple lesions everywhere, which is the case of mononeuritis multiplex. So when things get messier and you really don't know the localization, you have to step back and say, like, am I doing this a disservice, trying to like narrow it down to a localization, or can I like think broadly? I'm sorry. And so, you know, try to localize it if you can. If you can't, try to think multiple things being affected. And so we definitely had like diplopia, which is also a gravitational sign in this case, because, you know, even neuro diseases don't have a lot of diplopia, so that's a rare, and you really have to think about it. I definitely consider places where multiple cranial nerves can be affected. We tend to think of the brainstem because brainstem has heavy traffic. Subarachnoid space can also involve like all of cranial nerves. So I definitely like to highlight that and think of diseases that affect the subarachnoid space, and we'll definitely take that that teaching point with me. You can also think of like cavernous sinus or neuromuscular junction. And then we had also leg weakness, and we did the central versus peripheral, upper motor neuron, lower motor neuron. And then we had like cranial nerves versus with a peripheral disease. And that's where things got complicated. And we started thinking, you know, we can't really localize this to one thing. That got trickier when the patient had systemic signs such as the splenomegaly, the elevated LDH, the cytopenias, and that's where we thought, this is not neuro, okay? Neuro really sounds neuro. Neuro is very neuro heavy, and then like neurological diseases usually don't have a lot of systemic findings, but any systemic disease can cause neurologic findings. So that's where we like stood back and said, okay, this might not be neuro. Let's focus on like the internal medicine side. And moving away from the neuro, we started thinking about neoplastic, infectious, or autoimmune. And with further workup, we got the final diagnosis. But it was a great ride and a great reflection at the end. And I definitely love the case, Geraldine. Thank you so much. And the reflection